Good afternoon, everyone. It's my pleasure to be here with you to discuss the new Phantom Encore Bioresorbable Scaffold. As we all know, coronary revascularization started on 1960 by Cabbage, which then progressed to balloon angioplasty on 1977, and then bare metal stenting, drug-eluting stent, drug-coated balloon, until we reached the bioresorbable drug-eluting scaffold on 2013. Today we're going to discuss the third generation of the bioresorbable scaffold, which is the Phantom Encore scaffold system, which was developed on 2018 and obtained the CE mark on June 2020. This scaffold is designed, it is characterized by thin struts that range from 95 to 125, in contrary to the old first generation, which was 150. It is mounted on semi-compliant balloon with a crossing profile of 1.35 millimeters. It's mainly characterized by the Tyrocore polymer, which is derived from the natural tyrosine amino acid that allow low inflammation and irritation rate, most probably due to low lactic acid concentration inside the vessel during degradation. It allows vessel uncaging within 1 year, while complete resorption occurs in around 4 years. This polymer is covered by sirolimus coating, which is highly lipophilic anti-proliferative drug, which efficacy was demonstrated in multiple clinical studies. The benefits of the Tyrocore polymer usually is ultimate tensile strength that range from 100 to 110 MPa. This allows thinner struts with enhanced radial strength and minimal recoil. High ductility, which allows elongation at breaks. It reaches up to 120 to 200%. This allows single-step inflation, in contrary to the progressive inflation of the previous generations. Also, it allows larger expansion range, as we will show. It's also the first bioresorbable scaffold, which is radio-opaque, which allows accurate placement during implantation. The biodegradation occurs through hydrolysis, enzymes, and cell metabolism. The scaffold is broken down into water, carbon dioxide, and iodine, which are all natural metabolites that can be excreted through the kidneys and lungs. The Phantom Encore scaffold provides structural support for the first 6 months post-implantation, which is a period of vessel healing. After 6 months, the scaffold starts to disappear until 1 year, while complete bioresorption occur within 4 years. These are the available sizes of the Phantom Encore, which is diameters of 2.5 millimeters, 3, 3.5, and 4 millimeters. And all 4 diameters come in 5 lengths, which are 12, 18, 24, 36, and 48 millimeters. This scaffold is characterized by a high expansion rate, where the 2.5 millimeters can reach up to 3.25 millimeter, and the 3 can reach up to 3.75. The 3.5 can reach up to 4 millimeters, and the 4 millimeters can reach up to 4.5 millimeters. Clinical studies for the Phantom Encore. It was studied in multiple clinical studies. The largest was Phantom 2 cohort A and B, which was published earlier this year in the Euro Intervention. The main results for this study that included 240 patients, and with 5 years follow-up, the MACE rate was 6.3%. Both cardiac death and MI were 1.7%. Clinical TLR 3.3%, while the target lesion failure was 5.8%, which was lower than both arms for the Absorb 3 trial. Regarding the scaffold thrombosis, which was the main cause of the scaffold setback, as we all know, on 2017, there were no reported cases of neither acute nor late scaffold thrombosis, while subacute scaffold thrombosis was reported in 0.4%, and the very late scaffold thrombosis was reported in 0.8%. But for sure, larger studies are still awaited, such as the Phantom post-market trial, which is actively enrolling now, and it's expected to include 1,500 patients. Regarding the Phantom Encore implantation technique, the first step, I think it's the most important step, which is proper patient and lesion selection. And then pre-dilatation using NC balloon at 1:1 vessel size. After pre-dilatation, residual stenosis should be less than 30%. If it's more than 30%, do not go for this Phantom Encore. And then scaffold size selection within the expansion limit according to the treated segment. And then careful scaffold preparation and proper scaffold positioning. I think it's much easier with this radio opacity. Then balloon inflation in one continuous step, but pressure should be maintained for at least 30 seconds, followed by post-dilatation using NC balloon at 1:1 vessel size while avoiding overexpansion. Regarding the patient and lesion selection, this Phantom Encore is encouraged to be used in de novo lesions, type A, B1, and B2, with average vessel diameter ranging from 2.5 to 4 millimeters. It can be used cautiously in patients older than 65 years or those with ACS and positive markers, triple vessel disease, type C lesions, lesions with moderate calcification or more than 20% stenosis after pre-dilatation. Phantom Encore should not be used in patients with ejection fraction less than 30%, those with renal failure, those with triple therapy, DAPT intolerance, or planned surgical intervention within 1 year. They should not be used in left main coronary artery, whether arterial or venous grafts, ostial lesions, bifurcations, end-stent restenosis, highly tortuous or calcified vessels, or vessels with average diameter less than 2.5 or more than 4 millimeters. Regarding the scaffold preparation, the most important step is the removal of the protective sleeve and shipping mandrel. As we can see here, the first step, we have to hold both the inner and outer sleeve, the white one and the blue one. Cautious, you should not at all hold this one, the balloon shaft. And then slide the blue outer sleeve until it touches the flare of the shipping mandrel. At the last step, the balloon shaft can be held to remove the entire sleeve and shipping mandrel as one unit. Attention to avoid pinching the scaffold or balloon cone during sleeve removal. After sleeve removal, we have to verify that the scaffold is positioned just in between the proximal and distal balloon markers. And we have to check for kinks, bends, and other damage, sure without touching the balloon cone or the scaffold. And this is how it looks after inflation. Sure, we should not inflate it outside the coronary artery. Also, we should not forget the role of intracoronary imaging during implantation, pre-stenting, to assess the morphology and exclude moderate and heavy calcification, and also to choose the proper length and diameter of the scaffold. And post-stenting to exclude significant medial dissection and to ensure proper apposition and proper expansion. Thank you.